So I work for MAPS, and I'm a therapist. And how many people are therapists or therapy students here? Okay, so we have quite a few. I'm going to be talking about trauma, and it's really difficult stuff, so I encourage everyone to check in with yourself. You know, I don't have a lot of time, so I'm going to kind of fast forward through the beginning. This is MDMA, and Sasha Shulgin synthesized MDMA in 1965, and he gave it to a therapist friend of his, Leo Zeff, and it became an underground medicine used in therapy. Thousands of therapists were using this. And there's a book about the work of Leo Zeff called The Secret Chief Revealed. And it was called A Year of Therapy in 2 Hours. And in 1985, the DA placed MDMA in Schedule 1. And I think this would be its own entire talk. But that's when MAPS, in 1986, to educate the public honestly about the risks and benefits of psychedelics and marijuana, to treat people by building a network of clinics where treatments can be provided, and to treat conditions that conventional medicines aren't working for. And this is a quote by Sasha Shulgin. "You ask me how I feel about the past 20 years. Am I happy about where MDMA stands now? No, I'm quite sad. Here is a compound, an incredibly safe compound when used appropriately, that has the potential of giving pleasure to the user and of being of medical value to those who have certain psychological problems. It is thus both an affirmative and a curative agent, and yet for political and self-serving reasons, the authorities have demonized it and made it a felony to possess and use." So I'm going to not be talking about recreational use. I'm going to be talking about the studies that we're doing to treat people with post-traumatic stress disorder. And what post-traumatic stress disorder is, for someone who has PTSD, they were exposed to a traumatic event and they continue to re-experience the event all the time in their life. And they go between feeling avoidance, so they might avoid a stimulus that reminds them of it, and feeling increased arousal. It affects 6 to 10% of the general population, and I think it's really important to remember how much people with PTSD are suffering. We lose more soldiers to suicide than we do in war. And these are the current methods. Cognitive behavioral therapy, EMDR, psychodynamic psychotherapy, and psychopharmacology. So, you know, antidepressant, those kind of medications. And 25 to 50% of people don't respond to what's being offered now. So why MDMA? MDMA magnifies what's there. It magnifies feelings of well-being, bliss, affirming, joyful, and also painful feelings. In therapy, it's really important to trust your therapist, and MDMA enhances interpersonal trust. Unlike other psychedelics, there's little alteration in feelings of self or control over the experience, and also difficult experiences do come up. So it's not a party or a rave, it's a therapy session. And so this is an actual quote of a client that said, I don't know why they call this ecstasy. In treating people with PTSD, the obstacles are fear, defensiveness, and lack of trust. So it takes a really long time to build trust with a client. They'll feel afraid to talk about their trauma. They'll feel hyperarousal, so in talking about their trauma, they'll start to re-experience it. It's very common if I'm treating a client with PTSD that if we touch on the trauma that they won't come back next week. So what it does is it allows for an optimal arousal zone, window of tolerance, and it gives a realistic perspective about the person's current sense of safety. And we have a specific therapeutic approach that we use in our studies. There's a safe container, there's an inner healing intelligence. So we believe that there is something inside a person that the medicine enhances, and that the therapists are like guides, but there is an inner healing intelligence inside everyone. And there's a support over encouraging whatever comes up. And so we had a pilot study, and we have a current study now that's with WarVet. And these are the therapists, Michael and Annie Mithoffer. And this is kind of our timeline. So in 2010, we had our 3.5-year follow-up. Our pilot study was published in the Journal of Psychopharmacology. And we've had a 3.5-year follow-up, so that's really good. And this is the therapy room. It's in Charleston, South Carolina. It's really homey and comfortable. As you can see, or if you can't see, there's like a futon bed. We always have 2 therapists, a man and woman. That's part of Stan Groff kind of started that tradition. And there's music and there's eye shades. And so for the experimental session or the medicine session, the client has a choice of going inward and listening to music and having eye shades and interacting with the therapist. They do have to take their blood pressure every hour, so they do interact with them or interrupt them during that time. So as I said, the foundation, these are like our forefathers, Stan Groff and Greer and Metzner. So I don't have time to get into Groff's cartography, but it is a way that we think about what's happening, sensory, biographical, perinatal, and transpersonal. And so there is a physical things happening, there's biographical, so that is the story about the trauma, and Groff's theory about the perinatal, and there is the transpersonal and spiritual. And oh, I think I already said this, the safe container. So we have 3 types of session. Introductory session, the experimental sessions where you get either a placebo or the medicine, and then follow-up integration. And this is how they look. I know not everyone can see. So there's a screening to see if you can get into, be in the study. And then once you're in the study, you have 3 90-minute intro sessions. And I'll go over that. And then there's an experimental session, so that's 8 hours long. And then there's another 3 90-minute sessions, and then another experimental session, and then another 3. So you can see it's not, you don't just give someone MDMA and leave them. Yeah?
Are they double blind?
Yeah, they're double blind. There's a lot more I can say about that, but in the pilot, it was either you got it or you didn't, so people, you know pretty quickly if you didn't get it.
Does the therapist know?
The therapist doesn't know, no. And then in our follow-up studies, there's different dosages. But as you can see, there's a lot of integration sessions. I don't know if during the experimental session, the client gets 125 milligrams, and 2 hours later they get half dose, 62.5. So it does last for 8 hours. And in the introductory session, you get the history of the client. You educate them. You explain, and the therapists make an agreement with the client that they'll bring up the trauma if it doesn't come up. That's never happened. It always comes up from the client. And if you think about people with PTSD, it's right below the surface. It's there. They're always living with it. So, encouraging to go through it, to validate and value positive affirming experiences, and encourage people to follow their bodily sensation and movement. There's also kind of a contract about touch, whether the client wants to be touched. The therapist might massage them. So discuss optional touch. There's an agreement not to leave, and they explain the music and the silence. So the client does sleep there that night. There's an overnight nurse there they can choose to talk to. And it's a really supportive environment. Annie makes them soup, and they're always available to call if anything comes up. So this is kind of our general principles of what we look for in the experimental sessions. It's really about creating a sense of safety and support. So here's some quotes from actual sessions that the therapist said. We want to reaffirm our commitment to be present for you. We will make this a safe place for you to have whatever comes up. If something difficult comes up, try to stay with it and fully experience it. Use your breath to move into it. Don't get ahead of the medicine. That's something Michael says a lot. Don't get ahead of the medicine. Ask for anything you need. We'll encourage you to have alternating periods of going inside, using eye shades, listening to music if you want to, and then talking to us when you feel like it. And here's quotes. So I'm a qualitative researcher, so that I like the quotes more than the graphs, but I'll have both. Here's quotes from from different clients. I feel a whole deeper level of consciousness, calmer peacefulness. I don't remember ever having this. My mind has never been at peace like this. I had never before felt what I have felt today in terms of loving connection. I'm not sure I can reach it again without MDMA, but I'm not without hope that it's possible. Maybe it's like having an aerial map, so now I know there's a trail. I got a glimpse of what I'm capable of growing into. I'm motivated to keep practicing openness until it gets more developed. And this is examples of our non-directive approach. Would you like to tell us more about that? I just noticed that your voice changes or something going on that you notice. Or would you be willing to experiment with not distracting yourself that way for a few minutes just to see what you might discover? And then the integrative sessions are the sessions after. And so those are really important to process dialogue, validate, and reinforce ongoing healing. Here's some quotes, challenges in integration. Client said, the anger feels like a volcano. I'm afraid of being a one-man wrecking crew. I feel such sadness, loneliness, nausea. Since I've realized how shut down I've been, I don't ever want to go back to being that way, so I'm having a hard time. After all these years of not talking about it, was it really safe to reveal that I felt physical pleasure along with horror when I was abused? Now that the medicine is worn off, I sometimes feel guilty for saying the things I did about my parents not being emotionally available. I know it wasn't about blame, but there's still that judging voice that says we don't talk about any of this. So those are things that are really important to process with the therapist after. And here's some quotes from results. What's most comforting is knowing now I can handle difficult feelings without being overwhelmed. Being able to feel again is indescribable, like a blind person being able to see again. I used to have a barrier between me and everyone else. I can feel my body without having to make reference to the attack. My body is more than a victim, my body is my own. I don't think I would have survived another year. It's like night and day for me compared to other methods of therapy. Without MDMA, I didn't even know where I needed to go. Maybe one of the things the drugs does is let your mind relax and get out of the way because the mind is so protective about the injury. Without the study, I don't think I could have ever dug down deep. I was so afraid of the fear. In the sessions, there was just no fear. That builds your confidence. When I tried in therapy before, it would send me into a tailspin. It has felt like growing up. I feel wiser, more emotionally mature. It's like there have been ropes tied around me and now they're loosening. It wasn't an easy experience, but it was so worth it. It was a very spiritual experience, very expansive. I feel a sense of calm and stability now. I have a sense of much greater connection with a wise inner voice, inner knowing. It used to happen occasionally over the years, but now since the MDMA session, it's very common. Some think it's my inner wisdom, I think it's God. So here's, CAPS is a measure of PTSD, of post-traumatic stress disorder. And so this is, oh, the bottom got cut off. But, so each dot is after a session, after an experimental session, after a session with medicine. And the purple line is the placebo, and the yellow line is with MDMA. So placebo would be they just got therapy, and the yellow line would be they got the medicine, and you can see how dramatic their CAP scores went down. And this is from our follow-up. So they continued to get better. Almost everybody continued to get better 3.5 years after the study. And this is a questionnaire. So 50% said more sessions later would have helped. 20% said more sessions sooner would have helped. 0% of subjects reported harm. 100% reported benefit. So 2 people relapsed. So they had, yeah.
Are these only people who got the medicine, or are these
So everyone eventually got the medicine.
Oh.
Yeah. So yeah, this is everyone here got the medicine. 95% of subjects reported benefits lasting to present. So we had 2 people who something traumatic happened in their life and they relapsed. And this was the benefits. So 45% of people were able to stop seeing their therapist, and 55% were able to stop taking their psychiatric medications completely. One person who didn't get 3 sessions, this was early on, did MDMA again with a friend trying to have a therapy session, and they said they really regretted it, that it wasn't the same thing. But other than that, nobody did MDMA again, and I think that's important to show the public. So MDMA, these are our conclusions. It appears to be more effective than a placebo. Data suggests sustained benefit and no harm. And there weren't any negative effects. And you can read more about our studies at maps.org. And I'm happy to answer questions too. Yeah?
So I'm sorry, how long was the study and how many MDMA sessions were there?
Oh, let me go back.
Because was
So
it
there
months
were-
of therapy before any MDMA session?
Yeah. Yeah. There was therapy before the MDMA sessions.
Okay, but that looks like in minutes, not months, or am I not?
So after the screening, there are three therapy sessions, 3 90-minute therapy sessions before you have either an MDMA or a placebo.
Right, one after that, so you're spread out over weeks or months.
Spread out, yeah. Yeah.
Let's see. So my question is, how did you guys come up with the 8-hour experimental session, and how did patients feedback as to that duration of time?
Patients that got the experimental session of placebo oftentimes said that they preferred it, like it was like a good practice run for them. I think that the 8 hours, I would have to say, allowed for the medicine to wear off and the person to, talk it through, integrate it. I think that's, yeah. Yeah.
So a couple years ago, there was an article about a study
Yeah.
about permanent damage from ecstasy on the end bulb, you know, vesicles that
Yeah.
store the neurotransmitters, or I don't know if it also related to membrane structure of neuroreceptors, but it implied, man, maybe even one session, you're screwed permanently, achedonia, you know.
Yeah.
I don't know, memory.
So those were actually pretty old study, and they proved that it was done on monkeys, and that the lab had a mistake and was using amphetamines and not MDMA. High doses.
But that is an amphetamine. And
MDMA.
it is.
No, they used
the
it.
molecule. It's
Right, they used a
basically
different drug.
Okay.
They used a completely different drug than they said they were using, and so we do test the clients, you know, 3.5 years after, and there's been no cognitive effects of it. Yeah.
Your sample of clients, I'm wondering how many of them use like recreational drugs or medicines, or like have experience with substances.
Do you know, Evan? How many clients use recreational drugs? I think in our pilot, no one had used MDMA before. It's part of the screening. Okay, it's part of the screening, so no one was using MDMA before. Yeah. Yeah.
You know what's the difference between what we call mollies now and MDMA?
Well, if you're, unfortunately, if you're getting drugs, you don't know what you're getting. So
it could be anything.
it could be anything. Yeah. Could be anything. Yeah.
What is it particularly about the molecular structure of MDMA that creates this effect of bringing down defenses?
I don't know. What do you think, Evan? This is my research partner, Evan. We work on the studies, and we actually watch the videotapes of the sessions, and so I don't really know the answer.
Part of like what we're learning about.
Yeah, that's kind of the mystery that we're learning about. Yeah.
What was the question?
What exactly is it about the medicine that works?
Certainly a release of oxytocin.
Yeah, a release of oxytocin. Yeah. 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 So I'm a therapist. I'm not a sciencey person. So if you might see Vera. She works for MAPS. When she presents, she shows some brain slides more than I do. I like to show quotes. Hi. Did you have a question? Oh, okay. Yeah.
I wonder if you said, was this study just with ex-military or other?
So the pilot study, the one that had the 3.5-year follow-up, was it only had a few military people. It was all kinds of trauma, rape victims, childhood abuse, and the study that we're in the middle of now is all people who, you know, Iraq, Afghanistan.
So this study that you're reporting on, is that a big ex-military and other forms?
Yeah, it's mostly other.
Okay.
And the study happening now is all vets. Yeah. Yeah, great. Thank you. And MAPS.org, and we have a table outside. So if this speaks to you, please become a member. Thank you.